face in Lebanon and what we can do to help them. Please note that this webinar will be recorded and will be put on the ministry's website so you can revisit it and so other colleagues can also benefit from the knowledge that will be exchanged here. We will explore the topic of mental health and well-being of healthcare workers together with three eminent speakers, considering the many crises and the impressive resilience of our healthcare system in meeting the needs of the population and the impact on the mental health of the workers. We're very excited to kick off this webinar, which marks the beginning of a wonderful initiative by the Ministry of Public Health, the Australian Lebanese Medical Association, and IOM. This is a fantastic opportunity for Lebanese doctors from all around the globe to come together, share knowledge, and exchange experiences. I am Rabia Shamma'i, and I'll be the moderator for this session. I'm a psychiatrist and a psychoanalyst, and I have been working in the global mental health space for almost 20 years. I have the privilege of serving as the founding director of the National Mental Health Program at the Ministry of Public Health. Our program collaborates with over than 100 incredible partners to reform the mental health system towards evidence-based community mental health services aligned with human rights and cultural relevance. The program also chairs a coordination group with WHO and UNICEF aimed at addressing the mental health and psychosocial support needs of individuals and communities facing challenges during humanitarian crises such as the COVID pandemic, the Beirut port explosion, and the recent escalation of the aggression on Lebanon. We've created for you a helpful document that features a list of free evidence-based interventions that the ministry provides for free that you can easily access and you can easily share also with others. We will share this document with you and I'll talk more about it towards the end of this session. Now, without any further delay, it is my utmost pleasure and honor to present to you the Minister of Health, His Excellency Dr. Firas Abiad, whom I had the privilege of serving under his leadership through what may be the most challenging period for the healthcare system since the Civil War. His commitment, clarity of vision, and leadership has inspired many of us and allowed the health system in Lebanon to deliver and respond beyond expectations to the needs of the people during these terrible times, starting from the COVID to the recent aggression, and all of this on a background of one of the hardest economic crises in recent history. Dr. Abiad, I speak for myself and for many of my colleagues at MoPH and our partners when I express our deep gratitude to you and to your leadership. While we are pleased to see the political deadlock that the country has been experiencing over the last few years slowly resolving, we hope that your vision and efforts will continue to guide this new phase for the Ministry of Health. Much have been accomplished under your leadership, but there's still much to be done, building on your legacy. Dr. Abiad, the floor is yours, please.
So, good evening or good morning, everybody, and thank you all for being with us in this, what I'm sure is going to be a very important webinar. The reason this is an important webinar are multiple reasons, and I would like to explore some of them. First of all, I would like to thank the organizers of this webinar. And I must say that this is the first webinar, which is the result of the very important support that the Ministry of Public Health has received from our colleagues and compatriots, the Lebanese medical diaspora in Australia, spearheaded by the ALMA, the Australian Lebanese Medical Association, with my good friend, Dr. Walid Ahmad, and his colleagues, whom I had the pleasure of visiting and meeting back in June of last year. One of the things that you notice is really, despite the distance, the very overwhelming feelings that our colleagues and compatriots in Australia have for Lebanon. And indeed, I think this is the first organized collaboration between the Ministry of Public Health and the medical diaspora. And I really hope that this is a model for future collaboration with other medical associations as well. I must also here thank the International Organization of Migration, IOM, for the support that they have shown in linking between our medical migrants or our diaspora and their home country. And I think that this is a good model for collaboration, and hopefully it will allow this interaction between us and our diaspora will also play an important role in the rebuilding of Lebanon to where we all, whether here in Lebanon or whether abroad, would like to see our country. Now, having said that, I think, everybody knows that we have passed through extreme difficult times, especially over the past year. And I think that if you look at, the crises that the country has been passing through ever since the financial crisis, followed by COVID, followed by the port explosion, the migration, in the health sector, the cholera, then the earthquake, then the war on Lebanon, and all the others. It's very clear that our population are under severe mental stress. And as I remember after the explosion, I expressed my opinion at that time that as much as that explosion has left a lot of physical scars, but the mental scars on our community, I think, run much deeper. And unfortunately, because of several factors, they remain not as visible as the physical scars. Now, I believe that, people in Lebanon who have passed through the last war on Lebanon will agree that what we have passed through and witnessed is, an impact is way beyond any wars that we have passed through in the past decades. And I think that, one of the things that I noticed, for example, as I was touring on the internally displaced, more than 1.3 million individuals, one of the most sought after medication was magnesium. And at first I couldn't understand why people wanted this supplement. I thought that, the people would want chronic medications, hypertension. I couldn't understand why magnesium, till people told me that, this is something that everybody used to take for relief of anxiety and tension. And what I discovered is that really almost, I wouldn't say all, but the vast majority of the displaced population were on similar medications. Really, I believe that mental health is probably at the moment one of the most important areas that we need to attend to. Unfortunately, though, as much as we believe this is important, we see that a lot of work has been done on physical illness, but not on mental illness. And unfortunately, I think that we in the Ministry of Public Health and other guarantors have still way to go before we can properly address this issue with all its ramifications, whether it is the financial ramifications, the social ramifications, the physical ramifications, and others. And that's why I'm really happy here that this topic was chosen to be the first topic on this conference between us and our colleagues back in Australia. And here I really want to salute and give deep appreciation to the mental health program at the ministry, and yourself, Rabia, for really being very persistent and championing this very important topic, and also with all our partners, whether at the universities or in NGOs that really have been working with the ministry over the past years in support of people with mental health challenges. So I don't want to take a lot of your time. All I wanted to say that uh, crises, there are opportunities in crisis too, but I think that also crises allow certain precious metals to appear, let's say, as they say, forged in crisis. And I think that over the past year, the health sector has really proven that it is, I don't want to use the word resilient, but it's very capable and has, despite all the stresses that it has been under, it has been one of the few sectors that has delivered. And I think that that's not because it has a lot of resources, but it has a lot of very wonderful people, very dedicated, and I'm very happy that we will be listening to some of our colleagues who are part of this sector in this webinar. Finally, I want to express my deep appreciation to my friend and colleague, Dr. Walid Ahmad, because really for the past years, he have been the champion for the cause of Lebanon in Australia. And during my last visit, I could see how he was mobilizing his network of deep connections in all aspects of life in Australia for the support of Lebanon. And I think that, here, this collaboration with ALMA is one of the fruits of that, support. And I'm hoping that we will have other collaborations as well in the future. So thank you very much, Walid, to you and all our colleagues back in Australia. So with that, thank you very much, everyone. Thank you, Rabia, and back to you.
Thank you, Dr. Abiad, for your opening remarks and for your ongoing support for mental health. It is really rare to see ministers who have so many competing priorities interested in mental health, and your support has been crucial for the work of the program and has allowed it to be able to respond also alongside the other parts of the health system to the needs of the populations. As you said, the needs are big. But we're very confident with the network also that the program has built that we will keep moving forwards towards meeting those needs. The aim of this webinar is to address the mental health challenges faced by Lebanon's medical teams during the recent emergency response and to provide some guidance on supporting patients, particularly those presenting with psychological issues resulting from the war. And for that, ALMA and ILMA, International Lebanese Medical Association, have approached three distinguished speakers that will each present a different perspective on the topic. Before going into that, some housekeeping rules to make sure that the rest of the webinar is also very enjoyable and effective for us all. Please make sure that your microphones are muted. Maries will help us also to mute it in case you forgot to do so throughout the session to ensure a very smooth experience. There will be a Q&A session at the end of the presentations for about 20 minutes. And for that, please feel free to write your questions in the Q&A section. We will allow also then some interactions with the speaker. Please do raise your hands and you can unmute your mics then. Speakers will have up to 15 minutes, and Maris and I will help keep the time. So we will give you a signal at 10 minutes that you still have 5 minutes to go, just to make sure that we have also the time for interacting with the audience so they can ask you the questions that are relevant to them and you also responding to their needs. Just a small reminder to please, if you haven't filled the attendance sheet, to fill it. It's in the chat, and to present yourself also briefly so colleagues can get to know who's in the webinar with whom they are here. Before handing it to our first speaker, we will have a small poll. So you will have a question now, to which you have to select an answer. Maryse will put the poll, and then you can respond to it. And while you do this, I will be presenting our first speaker, Dr. Maya Bizri, who's a psychiatrist and a global mental health consultant. She is an assistant professor at AUB and has most recently worked at the Cleveland Clinic. Her interest is in global mental health and lies specifically in the mental health of healthcare workers in disaster and low resource setting. She's led missions in Ukraine and in Gaziantep. Dr. Bizri intervention is titled Beyond PTSD, Mental Health of Healthcare Workers in Conflict Setting. Before going to you, Dr. Bizri, we will see quickly the results of the first poll that just asked people how frequently do they take time to take care of themselves. And as we see, we have about half of the participant between not at all and just a little. And I think this is also a good representation of how we healthcare providers most often neglect our health, and we're more focused on others than on ourselves. I hope that after this webinar, we'll take a new resolution of better taking care of ourselves, having the tools and the techniques from our speakers. Without any further ado, to you, Dr. Bizri.
Thank you. Can you all hear me and see my screen?
Yes.
Okay. So first, thank you for inviting me. Thank you, Dr. Abiad. Thank you, Dr. Shammai. Thank you, ALMA and ILMA. It's a pleasure to be among much more seasoned colleagues than I am, but I'll talk a bit briefly about, because we are limited with time, I'll talk briefly about my experience in disaster settings and in war settings in healthcare workers. I think it's a topic that hits super close to home with all of us. And I think it's really what sparked my interest in global mental health to start with. And that's how I entered this sphere. So just trying to move my slide forward. Okay. So I always start my slides with just a few introduction. Just as a disclaimer, I didn't have any slides until today. I thought I would just talk about my experience. So I usually start with explaining why should we care. I know we had a small poll about whether all of us healthcare workers take care of ourselves. It usually goes very unnoticed, the distress that healthcare workers in general, not necessarily in just war zones, go through. So we've been taught that we are resilient as a profession. So we are taught, and there is this internalized stigma. So healthcare workers in war settings have been found really to suffer more psychosomatic symptoms than psychiatric symptoms in the literature. There is very little literature about that. But what is out there is that they suffer more psychiatric symptoms of anxiety, depression, and PTSD than actually, somatic symptoms than they would actually talk about. And why that matters is because it increases both the risk of psychiatric illnesses, as mentioned, but also of medical morbidities. So at baseline, in general, healthcare workers are about 20% or to 30% have a higher risk of chronic health conditions, whether that's metabolic syndromes, cardiovascular disease, etc. Now, those that are in crisis or disaster settings have an increased BMI, blood pressure, and serum cholesterol, and these were observed to persist even a year post-crisis resolution. So it doesn't only affect their performance, it doesn't only affect the way they interact with others, it doesn't only affect their mental health, but also their physical outcomes. And so I'll talk briefly about my experience, lessons from Beirut. I think all of you can speak much better than I do about this, but this is how we all started really working in disaster settings. And so for those of you that are, I think everyone here is Lebanese, but for all of you that are not Lebanese, in October 2019, which is when I moved back to Lebanon at first, is when there was the financial crisis. And then in March 2020, we had the first COVID wave. In August 2020, there was the Beirut blast. And in October, the second wave. and etc. Because I mean, obviously we haven't had it nonstop since then. And the first study of looking at what healthcare workers were going through during that phase, remember that was getting a hype in the States after the COVID pandemic, healthcare workers burnout, but really no one had looked at healthcare workers in disaster settings or war settings. And so in March 2020, so when the first when the first wave of COVID hit, we started looking at just AUB, our healthcare workers population, nurses, physicians, and about 60% showed rate of acute distress, but about a third had concern for PTSD. They had not had PTSD symptoms yet, and most of these were nurses. Now, very noticeably in that study, having a history of mental health does not mean you're automatically, it makes you the only one at higher risk of developing these symptoms. So we shouldn't only be screening or targeting any interventions to those that have a mental health history or a psychiatric history. So you have to assume that everyone is at risk. And then, we repeated that same study on a bigger level in December 2020. So interesting. First COVID wave was March 2020. Then we had the August blast, December 2020, second peak of COVID hit. And we had the multi-center online survey that we did that covered most hospitals. And they covered nurses, physicians across 5 or 6 centers. And the results here were a much higher risk of PTSD, especially in nurses, but in physicians, especially those, if you look, I mean, this is the only data that I could extrapolate to the current war. So I found those that were at higher risk most significantly were those that had homes severely damaged by the blast, that got injured the day of the blast, that had lost a relative. So things that are very relevant to the war that just happened. And 75% of physicians endorsed a willingness to migrate if they could find a job, which is very sad. So that was in 2020. And my understanding of mental health at that time, and I think it's very important because it shows you how naive I was going into the space, was only, depression, mental health in healthcare workers was, let's look for PTSD, let's look for distress, let's look for mental health, common mental health DSM symptoms. So depression, anxiety, and PTSD. And what this talk is about is looking at things beyond PTSD, because a lot of these things show subclinically. So these are things I've learned from, so after Beirut, I was because of the work we did in disaster psychiatry, we were contacted by an NGO to work in Ukraine in trauma-informed care. So we went and trained a group of healthcare workers that were non-mental health care workers, so they didn't have any background in mental health, and how to provide care for patients that have been traumatized, but also how to care for themselves and to care for their fellow physicians. And so that was about 2-3 years ago, a year into the war in Ukraine. And I'll talk briefly about what I've seen there, but the way we can react to traumatic stress at work can vary from one extreme to the other. Obviously, on one spectrum, you could be overly involved, overly wanting to help, and that could lead to compassion fatigue. But also you could be under-involved and move away from that and start feeling detached. And that's what people describe as burnout. And I'll talk about these terms. And so looking at the literature and what I've observed in Ukraine and then in Northwest Syria was that these terms are often used interchangeably, although they mean very different things clinically. So they are used to report negative psychological reactions due to indirect trauma exposure, but they are inherently very different processes. So people talk about secondary traumatic stress, vicarious trauma, compassion fatigue, burnout, moral injury, my favorite. I'll talk about these and how these differ from just looking for PTSD and why we shouldn't only be screening for PTSD or looking for PTSD. So what is vicarious trauma? Obviously, just as the word vicarious, living through the others, it's really much more cognitive of a process. It results from chronic exposure to trauma. And when I read that, I think a lot about the intergenerational trauma that we've lived in Lebanon as physicians as well. So no one physician just started with this COVID-19 stuff in 2019 and onto this war. They've had intergenerational trauma So vicarious trauma is inherently a process of cognitive change resulting from chronic empathic engagement with trauma survivors. There's a change in the way you view the world. So for example, you could be having thoughts, is it worth it to have a baby right now when there's this war with no end in sight? Is it worth it to buy a home? Is it worth it to really start a family? Is it worth it to get married if I was looking to get married? And so things that change your perspective of your worldview in sense, because there are issues of safety and control and trust, but also changes in spiritual beliefs. Like someone who's historically religious will start expressing doubt. If there's a higher being, why are things so unfair? Overly identifying with patients, having horror and rescue fantasies. And if you look at the definition, it's not related to PTSD. Some of these symptoms obviously overlap with PTSD, but PTSD at the very core is a fear-based hypervigilance, hyperarousal reaction that could lead to avoidance. But it doesn't have this cognitive change that you see here. And this is why it's important to, when we're talking to these patients, to really get more of a narrative view and a dimensional view of what their trauma experience is. And I'll talk about how that could affect the treatment. I can't move my slides, hold on. Okay. So that's basically the aspect, the secondary traumatic stress versus vicarious trauma. I try to put it in a table. So secondary traumatic stress is basically secondary PTSD when you weren't directly involved, but you're living it through your patients. And I think it's very important to note the difference that secondary traumatic stress symptoms are much more emotional distress symptoms from exposure to other people's traumas. The mitigation, the treatment for that would be stress, what we know for PTSD, stress management, peer support, a lot of the treatment of the physiological responses, including alpha-1 blockers, if you have nightmares or flashbacks or arousals, versus in vicarious traumatization, when the really dysfunctionality is very cognitive and you're questioning things, it needs long-term therapy and it needs meaning-making strategies, including making meaning of suffering. Does that make sense to people? If it doesn't, just interrupt me. Compassion fatigue, I won't go into it a lot just because I think it falls under burnout, which I think Dr. Soraya will talk about this more. I feel is more of an institutional issue, an organizational issue rather than a person's issue. A person may burn out, but the mitigation at the very core need to be beyond self-care, need to be at an organization or institutional level. And I think that's how it's very different from PTSD and from vicarious trauma. So it's a construct that has been hyped up since COVID-19 and even more now. It leads to it has three components: emotional exhaustion, depersonalization, feeling disconnected from your coworkers and from your work, and a very reduced sense of one's personal accomplishment or purpose. And I think a lot of the proposed solutions to those are really about organizational and structural changes rather than just a therapy intervention.
Dr. Bisley, 5 minutes.
Okay, moral injury, very quickly. Moral injury is my favorite, so because I think it's something we're going to hear about. It's a term borrowed by actually war research, and moral injury is basically, so I'll summarize this. It's basically when one person has to really live in a reality that does not align with their own values. So in terms of COVID, that was when healthcare workers, physicians had to pick who gets oxygen. In terms of war, people had to pick who gets the treatment. You want to provide the best care, but you don't have the resources for it. It leads to a lot of guilt, shame, distress. I have a very interesting example, and I think it applies to Lebanon, but this was from Ukraine. So when we went, part of the treatment we did was about psychological for just promoting positive thinking. And so you have to write your unuseful thought with that group we were training and then replace it with a positive thought. And you know, in Ukraine, a lot of the people are not very politically aligned. Some from the East are very pro-Russian, and they're internally displaced into the West. And I think that really applies a lot to the Lebanese demographic. And so someone wrote, my unuseful thought is I often want some people to die. IDPs, which are internally displaced people that get treatment in our children's hospital and say, I don't pity your boys dying, that were you, Banveristy is Western Ukrainians who started the war. And so you see how she's trying to really, because this is a noble profession that we have, and we want to provide care with people that do not necessarily align with our political views when we are very involved in this war. And so I think this is an example of moral injury. And a lot of the work here is not PTSD work. It's on it's based on really restoring meaning, community. It's working around the feelings of guilt and shame and moral repair and values. I'll go very briefly. This is a very important slide in disaster psychiatry because a lot of the distressing symptoms, a lot of the symptoms that are pathological will actually show up not post-disaster immediately. And I think Dr. Shammai, you know this very well, this slide that everyone puts. It shows up after a year after the anniversary. So if you want to deploy mental health efforts, if you want to deploy mental health efforts when you have low resources for them to really make the bang for your buck in terms of what you're going to catch and what you're going to get, you have to start those, especially if you have very low resources. And I know we all want to do very interventional stuff at the beginning, but you have to actually wait a year because that's when the actual pathologies that persist when everyone's gone back to norm will actually start to show up. And then my last slides are about substance use. We always forget it. We tend to use healthcare workers as resources rather than seeing them as a population at risk. In national trauma, you all know this slide. It's a very famous picture from what they caught at the port. This is a study that we wrote around review around national trauma and how much it's comorbid with substance use. And I think the substance may change, but I think the bulk of it is the substance may change, but it's found everywhere. In Lebanon, it's usually cannabis. In Ukraine, it was alcohol. Healthcare workers asked us to change our training and modify them to include training for other healthcare workers in substance use because they had seen their colleagues becoming more and more alcoholics. In Northwest Syria, this is from Azaz. It was the only mental health hospital. The only 2 patients I saw in Azaz were actually doctors. I remember that was a population that was pre-liberation of Syria. So that was a population of 4 million people that had only 2 psychiatrists. So people did not know how to do detox. They had shortages of medications. So you have to be really flexible around and really be open about screening for these in primary care settings and in low resource settings, and flexible in terms of what treatments you can provide. My last slide, I hope I'm doing well on time. Who is at higher risk? Patients, obviously you all know this, people that have high caseloads, that are new to the training, that have an individual history of childhood trauma, intergenerational trauma in the case of Lebanon, but also de-skilled care workers. This very qualified physician that has been trained in endoscopic interventional spine surgery that is suddenly found in a traumatic setting in disaster settings in Beirut, and now he's just doing triaging of emergency care. A lot of the de-skilled physicians lose a sense of meaning and purpose. And so these are also at higher risk. Sorry, I'm cold. Okay. I'm done with time. Does that make sense? I tried to be quickly to go as
Dr. Bazziani, thank you for a presentation that is very nuanced and that provided a very good overview of the complexity and the differences between what goes under, burnout or well-being of healthcare workers. Because as you rightfully said, the interventions may differ either at the individual level or at the organizational level. I would like to remind our attendees, our participants, that please feel free to write in the Q&A section your questions from now for the speakers so we can go back to them at the end of the presentation. Feel free to write it while speakers are speaking as well. We will be moving now to the second speaker, Dr. George Karam, who's a friend and a psychiatrist specializing in adult and geriatric psychiatry. He is the chair of the Psychiatry and Clinical Psychology Department at St. George Hospital, University Medical Center, and Associate Dean for the Faculty of Academic Affairs at St. George University of Beirut. Dr. Karam serves on multiple national and international committees and is actively involved in mental health research with numerous peer-reviewed publications. He is also very engaged in community initiatives, notably as the CEO of IDRAC and the president of the Alzheimer Association in Lebanon. Dr. Karam will be talking to us today about caring for ourselves and our patients in the aftermath of disaster. Dr. Karam, the floor is yours.
Thank you, Dr. Shamai. Thank you very much. Can you see my slide in presentation mode? Because for some reason, it's not showing as presentation mode for me.
It's not presentation mode. We can see this.
Okay.
Now it is.
Now it is, I think. Okay. So thank you. And in fact, Dr. Bizri just laid the ground a little bit for me in terms of the stressors that all of us go through. And what I wanted to focus on is, first of all, a disclaimer. You might find that my slides are very straightforward and very easy, and what I'm going to be talking about is straightforward, and this is done on purpose. I really wanted to keep the topic very accessible to everyone, and even though, I'm going to tell you things to do that you might say, yes, clearly we need to do that. Unfortunately, a big percentage of us are not doing the right things to take care of ourselves. So when we as the medical field are exposed to a trauma, we are exposed to the same trauma as much as our patients. So whenever a trauma is happening, we always have to keep that in mind, that everyone is affected. And sometimes the healthcare workers are affected even more so than the general population. And obviously, all of you know the COVID. If you're not living in Lebanon, at least you live the trauma and the burden of COVID, where some statistics show that, let's say in the US, 50% of doctors pre-COVID were burned out. After COVID, it was up to 62%. And here I'm talking about general doctors. I'm not talking about doctors that are working in ICU or the areas where they were really taking care of COVID. And in those areas, it was up to 90%. Another study was done in South Africa that showed that 70% of doctors post-COVID were burned out, and so on. Now, if you want to take the Lebanese case, where, as Dr. Shamai said at the beginning, we started us as doctors with the financial crisis. A lot of us lost all our money. We've been working, if I want to talk about myself, I've been working in Lebanon for 15, 20 years trying to make some savings, and then suddenly out of nowhere, I lost everything. You add to it the COVID and the challenges of COVID, and then August 4, 2020, the blast happened that affected everyone that was in Beirut. And if I want to tell you a little small personal story, so I was in a meeting in Gemmayze, which is not far away from the hospital where I work in Ashrafiyeh. And then I get out, confused about what happened. No one knew what happened, and just dazzled about the amount of destruction and walking dazed in the streets. And my dad calls me to tell me that my stepmom, who is also a clinical psychologist with us, he tells me, I'm calling MA and MA is not answering, and someone told me that she lost consciousness. I don't know what to do, and I hear my dad crying. It was a big shock, so I start running to the hospital to see what to do, because there was no way to drive there, and it took me a good 10 minutes to get to the hospital running. I get to the hospital expecting that the explosion happened where I was, to get to the hospital to see that in fact the hospital was completely destroyed and everyone was completely lost and not knowing what to do. So here I am a doctor trying to take care of a family member, yet at the same time traumatized myself, at the same time people rushing to the emergency room to get help. I'm a psychiatrist, so I am not versed into taking care of traumatic injuries and so on, yet I was there and I had to do, what anyone had to do to take care of patients. I come back home that evening, at midnight, and then we realized that in fact I lost everything. My office was completely destroyed. Our NGO, the offices were destroyed. We had a family member that was hospitalized. And it was a big shock. And what do you do in a case like this when, in fact, you are a doctor, you're supposed to be taking care of patients, yet you are the patient somewhere, at least on the moral injury, at least that Maya was talking about. And it took us 2 days, in fact. So the explosion was on Tuesday, and the conversation started happening on Wednesday. So we had a Zoom call, the whole department, that, okay, what do we need to do? We are affected big time, yet we have a population that we need to serve. We cannot give up. We cannot be just sitting on the sidelines. So we had urgent meetings all of Wednesday in order to start a walk-in clinic on Thursday to help anyone that was affected in the community. And some of the things that we were doing, when you have a walk-in clinic and people that are traumatized, are some of the things, basic psychological first aid that I'm going to talk about in a second. But that was an important lesson to me, and that's what I want to convey the message, that it is really important to take care of yourself. As doctors, if you're not taking care of yourself, you'll not be able to take care of your patients. It's like a cell phone. If your cell phone is not charged, how are you going to be able to use it? So please do take care of yourself. And I'm not too surprised when I saw the poll that 50% of you do not take care of yourself as much as you want to. So it's really important to always keep in mind that, all of us are stressed. All of us will experience grief when we are in a traumatic event. All of us can have anxiety. So the symptoms that we are experiencing could be very normal. And that's why it will be really very much needed to share our experiences and to talk to colleagues and to really not to be ashamed and not to hide behind our finger that, we are doctors, we are the ones who are supposed to help, what to do. No, it is okay to be getting help. And in fact, in some training, in some psychiatric trainings, in some residencies, they do oblige or they strongly encourage, the residents, psychiatric residents to undergo their own therapy. So it is really important to be able to go to know yourself and to help yourself to be able to help others. So some of the things that are really important are to put boundaries. And I know that your patients come first. I know that. But, somewhere, no, I should say that you come first. And you have to be a little bit selfish. You have to take care of yourself. You have to put yourself first in order to be able to take care of your patients. So learn how to say no. And when you are in a stressful situation, maybe the demands will increase on you, and it is important to prioritize, what is important at the present time and what is not. And frequently I find myself burnt out, like once a month I find myself burnt out, and then I realize, why am I getting burnt out? It's because I'm taking too many responsibilities at the same time, and every time there is a new committee, every time there's a new conference, every time there's a new course to teach, I'm saying yes to everyone, and then I find myself at the end of the month really burnt out. So I learned now to really screen and decide what I want to do, which conferences I want to do, which committee I want to join, and not just join everything just like that blindly. The second thing that is extremely helpful, and I know that all of you know that, and I know that maybe the large majority of you advise your patients to do so, yet I know that the majority of you do not do it enough, which is exercise. Exercise has been proven over and over and over again, no matter which study you're looking at. Exercise has been proven to be the best stress reliever, the best prevention in terms of psychiatric disorders, the best prevention for Alzheimer's, the best prevention for cardiovascular disease, the best prevention for diabetes. So any disorder that you look at, the best prevention for cancers, really, literally any disease that you look at, the best prevention from not having this disease is exercise. And all of you know that, and all of you encourage your patients. What I'm surprised is that how many doctors do not know what exercise means or how much time you need to be spending to exercising to take care of yourself. And if we had time, I would have asked a poll to see how many of you know what is the correct answer, but I'm going to give you the correct answer. If you look at the WHO, what they tell you is that every one of us has to be exercising between 150 minutes and 300 minutes on a weekly basis, doing aerobic activities. So if I want to take the lower amount, which is the at least 150 minutes per week, that means 2.5 hours per week doing aerobic exercises. And that should be coupled with at least twice a week of resistance training, where you are doing, muscular training, musculation, where you are building your muscles. So if you look at the amount of exercise that the WHO recommends, I think that all of us are far from this amount where we are not, doing 2.5 hours on a weekly basis of aerobics and add to it 2 hours of resistance training. So please, start doing that. It is extremely helpful. And, I do it. Rabia knows that, I'm an avid runner and Rabia is a runner. Once I started doing it in 2018, I was not a runner. I was not someone that engaged in exercise before. So I'm a newbie, if you want, in that field. But once I start doing it, and I do routinely, I exercise 5 times a week, I can tell you that, believe me, my mood changed, my energy level changed, my concentration changed, everything changed. And I know you know that. I know you advocate for your patients, but please, you are the patient, advocate it for yourself. Also, nutrition. All of us know how much
10 minutes past, Dr. Karim.
Okay. All of us know how much nutrition is important. So please, healthy diet, the Mediterranean diet, all of us know that. Try to apply it, especially if you're not living in Lebanon. Try to maintain your nutrition. It's extremely helpful. And sleep, all of us as doctors, we do suffer from sleep deprivation. It is really important to maintain a good sleep hygiene and sleep techniques. Now, if all of that does not work out, then, consulting a specialist and joining deep breathing sessions would be extremely helpful. Breathing techniques, it's so simple, so easy, free of charge. And if you don't know how to do it, you can just go to the Ministry of Health. In fact, there is a nice video that is posted on the Ministry of Health that shows you how to do the breathing technique, which is it's just as simple as taking a deep breath in for 4 seconds, keeping the breath in your chest for 4 seconds, and then exhaling for another 4 seconds. It's as easy as that. And if you do it 3-4 times in a row, your system will automatically slow down and your anxiety will slow down and you will feel better. And you can do it anywhere. You can do it while doing surgery. You can do it while driving. You can do it while writing your notes. Anywhere you want, you can do the deep breathing technique. Also, practicing mindfulness just 10 minutes per day is extremely helpful. And there are so many YouTube channels and apps, free apps that you can download that will teach you the basic techniques. It is so easy, so simple, yet so powerful to do. Now, when it comes to our patients, you need to teach them to be doing the same things that I just told you. But what you need to do with your patients also when they are facing a traumatic event is to be there and to actively listen to their concerns and to really validate their emotions. It is important not to be judging patients. It is really important to have an open-minded and not to force anyone to talk about the stressor. And this is really important because until 10, 15 years ago, we used to think that debriefing is extremely important. And anytime someone has a trauma, you need to bring them right away and they need to debrief and talk about their events, when in fact, newer studies are showing that that can be more harmful than helpful. So if someone wants to talk about their emotions, you encourage them and you are there and you're actively listening, but please do not force anyone to be talking. Also, normalize their reactions. It is important to tell them what they are feeling is normal, that everyone is feeling the same, and what to expect, and that, once you are under a stressor, that probably it is normal to be having nightmares, not to be eating well, and so on. But with time, with the few days that come, things will improve, and around 95% within 1 month will not have any symptoms anymore. It's only a small percentage of people that will continue on having symptoms after 1 month and will go on developing PTSD. So try to normalize, the disaster reactions. Now, the first aid, psychological first aid, just very briefly, it means, to be there to assess the safety and the needs of the patient, to offer comfort and empathy, and to try to connect them to resources. If you're not a psychiatrist yourself, try to connect them. And in fact, the Ministry of Health does an excellent job where they have the 4 Ws. It is readily available on the website of the Ministry of Health, where you can just log in and you know where to refer your patients and who's offering what. So the resources are available, and please do take care of that. Now, encourage your patients and yourself to stay connected with your social network. It is really important. And the one thing that is still very positive in Lebanon is the social connectiveness that we have. And the more you're connected with your families and friends, the better it is. And so please take advantage of that. And you don't need to do big goals and big changes to be taking care of yourself or taking care of your patients. Just small goals, small things. So when I'm saying 150 minutes per week, start with 10 minutes. You know, start with 10 minutes. That's already better than zero. The 10 minutes will become 15. The 15 will become 20 until you reach, you know, where you want to reach. So please, you know, focus on small goals. The aim is to do it. The aim is not to be doing everything at the same time. And the more you practice self-compassion, the better you are. So very quickly, as a summary, take care of yourself to be able to take care of your patients. And remember that the care we provide to others is only as good as the care we provide to ourselves. Thank you. And
Thank you. Yeah.
thank you. I just wanted, you know, I'm really sorry, I forgot to thank the organizers about the invitation at the beginning. So I really want to thank you, you know, for the invitation, and I was really happy to be part of this panel.
We're very grateful that also you're with us, Dr. Karam, and thank you for, you know, just reminding us about the basics, but those basics that are foundations of what we as individuals, where our responsibility lies. And I think this provides a good segue to the intervention of Dr. Suraya Torbey, because it's not only our responsibility either, right? So there are other factors around us that can help promote our mental health or negatively impact that. Just a reminder to our participants, if you have questions, please put them in the Q&A section, so we make sure we address them to the speakers at the end. And now it's my pleasure to present to you Dr. Suraya Torbey, who's a child and adolescent psychiatrist at Kennedy Krieger Institute, where she works in the Center for Developmental Behavioral Health. Dr. Torbey is the director of the Integrated Health and Behavioral Clinic and co-directs the Functional Neurological Symptoms Disorder Clinic. She is also an assistant professor at Johns Hopkins University School of Medicine. Dr. Torbey's professional interests include interdisciplinary care of complex patients, somatic symptoms disorders, and pediatric chronic pain. Her intervention will be on institutional approaches to address clinician wellness in post-conflict. Dr. Torbey, the floor is yours.
Thank you for the introduction. Good evening, everyone. I'm really excited to be here today. I wanted to thank everyone, Dr. Abiad, the Ministry of Health, Dr. Ahmar, Dr. Shamain, the ALMA and the ILMA for inviting me to speak at this important event. This topic is very important to me. I was very involved in physician wellness during the COVID-19 pandemic, so I'm excited to talk about it. Healthcare worker well-being isn't just about supporting individuals who make up the critical workforce. It's also ensuring that they're equipped to perform their jobs at the highest level, and prioritizing that creates a more sustainable, effective healthcare system. So bear with me, there's a lot I'm going to try to cover today. Don't have any disclosures. In this talk today, I'm going to define physician burnout, which I think my colleagues have alluded to a little bit. I'm going to list some general institutional strategies for wellness of staff, and then we're going to focus more on organizational approaches specific to post-conflict. So they say a picture is worth 1,000 words. I think this cartoon does a great job of capturing what it's like to be a physician at times. This lady's telling the physician, "I feel the way you look." And I think that's kind of my experience sometimes. I mean, how many of us have gone to work feeling under the weather, battling a migraine, dealing with some stressful event in our life? I'm sure a lot of us have done that. The idea of burnout is not a new idea. It really dates back to ancient civilizations, but we don't have time to kind of focus on that a lot today. But I'm going to focus on how it came to become what we know it currently. In 1889, Sir William Osler said, "In the physician or surgeon, no quality takes rank with imperturbability." He asked graduates to have coolness of mind under all circumstances. But I mean, looking at this quote, I mean, I'm being unfair to him because he did think about wellness, but are we really imperturbable? I don't think so. I think physicians nowadays are a pretty unhappy bunch. In 1974, Herbert Freudenberger actually coined the term burnout. He recognized that physicians were not really faring well. Christina Maslach continued to expand on that concept, and she actually created the Maslach Burnout Inventory. Dr. Bizri already kind of talked a little bit about these three categories where we look at emotional exhaustion, personal accomplishments / like fulfillment, and depersonalization. So basically, we're looking at how exhausted, cynical, and inefficient we are. This is a question for you guys. Dr. Karam already kind of alluded to what the answer is going to be, but in general, how many physicians report at least one symptom of burnout? And choose the closest: 5, 10, 80, and 50%. It's around 50%. Most recently, post-COVID, the numbers have been a little bit lower, and that's the first time they've been that low in a long time. So why do we care? I know my colleagues already talked a little bit about that, but first, because we're decent human beings, hopefully. 2, because it results in a lot of significant negative impact on physician well-being. It leads to a lot of medical errors. So on an institutional levels, we care for a different reason, right? It results in a lot of medical errors. It impacts physician performance. It decreases productivity. In the US, burnout costs around $4.6 billion annually. There are a lot of factors that impact clinician wellness, and I know my colleagues have talked a little bit about that before, but in order to understand the problem, we need to understand the causes. So there's a lot of causes. One, the practice of medicine. Medicine is a stressful job. We also have stressors from our specific jobs, right? In psychiatry, by the end of my day, working with like very medically ill kids who also have psychiatric illness, I'm drained at the end of the day. A surgeon might be physically tired from standing all day. We have poor work-life balance. We're conditioned to never show our weakness. That's one of the ones I really bothers me. I really stress into our fellows, it's okay to not be okay. Imposter syndrome by itself has actually been correlated to burnout. The higher that feeling of imposter syndrome, the more burnt out people were. Character traits, if you're vulnerable, poor leadership from supervisor, we're going to talk about that in a second. Secondhand victim experience, which Dr. Bizri already alluded to. If you have a patient that dies, that's kind of secondhand experience. Personal stressors and situational stressors. So again, medicine's a chronic stress. It's a state of chronic stress, right? Or the demands are always outweighing the resources that we have. This figure illustrates some of the details of this mechanism. I'm not going to go into it in details for the sake of time, but remembering the psychobiological causes and differences between acute versus chronic stress that Dr. Bizri was talking about. In the end, when chronic stress impacts our body and puts physicians not only at risk of like burnout and other conditions that we're going to talk about, but also at risk of medical illness, right? Increased blood pressure, all sorts of other things with biologically. It also increases our risk of depression, anxiety, PTSD, suicide. That's been controversial most recently in physicians, substance use. So really puts us at a lot of risk. So now let's add war to it. These are some of the unique factors that we see more, right? Persistent risk of death, separation from loved ones. We have long shifts. People, my friends would tell me they're stuck in the hospital, can't go home for weeks, witnessing traumatic images, death, working during a surge, being really overburdened, taking multiple shifts in a row, and hopelessness that Dr. Bizri talked a lot about, that hopelessness, that really, the emotional drain that not being able to kind of, not really PTSD, but a state of like a lot of malaise, fatigue, and burnout. Buddha said, to keep the body in good health is a duty. Otherwise, we shall not be able to keep our minds strong and clear. So how do we move forward? How do we keep physicians' minds strong and clear? Christine Sinsky says that while burnout manifests in individuals, it originates in the systems, and it's the systems that are broken, not the people within. Christine Sinsky is one of the most prominent researchers in physician wellness. And so really looking at the system as a whole. This model depicts the factors associated with clinician well-being. So in the middle, you can see patient well-being. Then around that, the patient relation with their clinician. and then the clinician well-being, right? They're all impacted if the clinician is not doing well. And there are a lot of factors that play a role in a clinician not doing well: society, culture, rules and regulations, healthcare responsibilities. So it's obvious that the system at large needs to be addressed. The Stanford physician model proposed a framework for facilitating this process, for thinking about it from an institutional perspective. The goal is to increase professional fulfillment. And how do we do that? We want to increase personal resilience, but also the culture of wellness in the institution and the efficiency of practice of the institution and the individual. So we talked about burnout and we kind of defined that, but what's resilience? Why do we always talk about resilience when we're talking about trauma too? And why is it so important in physician wellness? Physicians have a higher rate of resilience than the general population, but studies show that once resilience is diminished, it actually highly impacts burnout. Physicians with resilience scores less than 50%, around 70% of them are going to experience burnout. So even most resilient people were emotionally exhausted and depersonalized. So it's our ability to adapt, to navigate our resources, right? It mediates the relationship between traumatic stress and PTSD. So it's really important to have high resilience in places that are wrought with like stress and trauma. And PTSD in conjunction with like perceived job stress and resilience, they really impact depression and alcohol use disorders, especially in first responders when you're exposed to trauma, which Dr. Bizri was talking about. This is a figure that illustrates the different individual, community, and organizational factors that play a role, the barriers, and the approaches for mitigating some of this distress. And we're going to talk about it more in details in the next few slides. So how do we build resilience? There's individual level, right? And then we have the organizational level. On an individual level, my colleagues have already talked about that, so I'm going to move forward. So what do we know about organizational levels and how to build resilience there? There's been a decent amount of research in this field that's led to a lot of evidence base, which is really nice. Not as much of research, honestly, almost none in regions where we have post-conflict and war. So anyone who wants to do research in that area, you're welcome to, because there's really nothing out there. So there's been a decent amount of research in there. But the first thing that we need to know is that the organizations have to accept that the change is inevitable. We have to change things. We can't continue doing things the way they do. So this is another question for you guys. Which of the following is essential for organizations to address in order to improve clinician wellness? Commitment, workforce assessment, leadership, policies, efficiency of the work environment, support, and all of the above. And obviously, all of the above. We're going to talk a little bit about them in detail. So in the next few slides, we'll discuss these strategies on an individual, group, leadership, and organizational level. So, sorry about that. So here in this slide, we're talking about organizational strategies aimed directly at the individual, not what the individual can do for themselves. So the organizations, for example, they can offer resources to support health. They can create employee assistant programs that you can call in order to whenever you're kind of in need of like counseling or things like that. They offer flexible work scheduling and working arrangements. So for example, like if you have to pick up your kids, maybe you can come a little bit earlier and then leave a little bit earlier so you can pick up your kids, things like that. We call that also and I'll talk a little bit more about that, but job crafting too. Let's say you're someone who likes more to do some resident education, then do more of that, less of the other thing that you don't really like as much, and someone else can do that. So on a leadership level, and that's very important, a lot of research has been done on that. Leadership, poor leadership has been shown to increase burnout by itself. Like engaging, we want them to engage, we want these leaders to engage people in realistic work demands and resource management. We want them to support, we want to provide them with support, but we also want them to support others, so support their staff and improve their, whoops, I have a typo here, and improve the performance feedback system. So we want them to know what's not going well so that they can also work on it. there's been there's been a couple of studies that have looked at the leadership qualities. Like I said, by itself, it can increase burnout. And so some of the things that they can do with providing leadership training.
5 minutes, Dr. Torbe.
We could provide leadership training, for example, for us as fellows, whenever someone gets picked for a chief resident or chief fellow, we actually have a leadership training where we also have like role-playing situations where how would you respond? What is a better way, more constructive way to respond so that makes you a better leader? A group, changing the policies and practices that reinforce negative work group norms, and then having a more cohesive group to group, like nurses interacting with like doctors, things like that, encouraging peer-to-peer support, which we're going to talk more about in details because that's very important. But for example, one of the group interventions is something called Compass, which is colleagues meeting to promote and sustain satisfaction groups, 6 to 8 people group that meets over 6 months every other week. And it has like a pretty good structure, and it's been shown to be helpful. So now let's talk a little bit more about the organization as a whole. So we want to increase the organizational support, improve some of the situational controls, like the way things are done in the organization. Sometimes all of us have gone there, like that makes literally no sense. It's so inefficient, right? And then conducting regular workforce health-being assessments. So actually, this has been shown to be very helpful. You could do it annually and make sure that make sure that you touch base on how your team's doing annually, and there's for example some resilience measures that you can give them to fill out like biannually or annually. So we want to reduce job demands. We want to get rid of stupid stuff. We all have had that happen, but we want to get rid of it. And we want to eliminate early morning, late afternoon meetings, improve EHR, decrease insurance dealings, which is a big deal over here, but I'm sure each institution will have something like that. But research has shown that folks don't want to come in early or leave late just for things that have to do with wellness. You have to really protect time during the day. That has been actually evidence-based to be helpful with burnout. And then improve the job resources, increase staffing if you can, improve like the clinical workflows, like instead of, this is just a short example, like instead of refilling a prescription every month, then refill it for 6 months. That way you don't have to deal with it or something like that. And then provide support, which we're going to talk about a little bit more. Peer-to-peer support is the one that's been shown to be the most helpful. There are different ways to do that. Peer coaching, buddy systems, you match them with someone their age who's going through something similar. And then, for example, like collegial dinners, wellness wagons where they have snacks, things like that. But research has actually shown that people actually don't like that as much as they like having someone to talk to versus a female. So Schwartz rounds, this is an evidence-based measure. It focuses on staff experience, not on the clinical care. It's been shown they usually meet every monthly. It's patient satisfaction, lower turnover, decreases absenteeism and clinical outcomes. So don't forget your trainees. They're a high-risk group. Around 75% of them report to be, I know I'm running a teeny bit late, report to actually be burnt out. After an internship, depression rates go up from like 4 to 26%. There's different frameworks for like trainees. Basically, you want to enhance the purpose, like Dr. Bizri was talking, and you do that by schedules, minimizing call, making sure that your policies, like you allow them to go to doctor's appointments during the day. If they have to, they don't have to do it on their vacation 6 months later. You want to make sure that their mental health is taken care of. That happens a lot that I've had to refer some of our fellows to be seen. So add war here. How does war change how we do things? So we talked a little bit about the factors before. So there are different factors that play a role, so different needs. I'm going to talk a little bit, like a couple of minutes, about the approaches that we took at Hawkins that I think could be implemented very easily in Lebanon. So we had support groups. I was part of them. We ran them. There were support groups from Monday to Friday. You could pick the day you wanted and come in. We limited the groups a little bit. Some of them were bigger than others. They were ran by some of the mental health care workers, but like me, but we were volunteer workers. So, and that's very easy to implement, right? And they were very well received and very well helpful. The ED group, which was very big, the emergency medicine group, and dealt with a lot of people that were going through a lot of stress, was ongoing even after the pandemic. We had regular mindfulness daily during the pandemic, can be done now. I think they still do it, probably monthly with Neta Gold at less frequency now. That's pretty easy to implement. Doesn't even have to be in one institution in Lebanon. Could be done by one person, rotate through institutions, things like that, volunteers. And finally, we get to RISE. RISE is a very formalized program and at Hopkins, which is utilizes psychological first aid, which Dr. Karam already talked a little bit about, so I'm not going to go into the details of it. But what we like about psychological first aid, it's not compulsory, like we said, but it also, you can train anyone to deliver it. So it's very universal, easy to implement. So, and you can also use it in individual and group, and folks really like the groups. So at Hopkins, what we did in the RISE program, there's a shorter version of the psychological first aid run by George Everly's group, who's a big name in disaster medicine. And so what we do is that all of there's a series of responders in this program. We call them responders. Basically, they're people who are part of the program. They're all trained in psychological first aid. And there's a person available 24/7 for anyone to call. And if they need it, if they're undergoing some kind of traumatic event, like let's say I have a patient who died, I call the RISE program, and the RISE program will have someone come to me within a few hours or a day. And you can also enroll in our groups. So this was a model. Basically, you want to make sure that the organization, whatever program you create, that you're disseminating it to all the managers. They're all aware of it. They can all refer to it. You also want to train these people a little bit in some kind of psychological first aid and in recognizing mental illness and who needs a higher level of care. So sometimes we did have to refer to higher levels of care, like the psychiatric department and things like that. So you want your staff on an organizational level to be aware of it. So just a quick clinical pearls: physician mental health is priority. Is a priority. And then burnout is a systems issue. It's not a person issue. War and conflict further complicate the picture. There's a lot of evidence-based organizational strategies and practices available if you look for them. And psychological first aid is a very helpful tool. And thank you. And I have some resources and.
Thank you, Dr. Turbay. I know we made the task impossible for you for all speakers to try to give us everything that would be helpful in 15 minutes. But I think you all did a great job, and I think there will be follow-ups for people who would like to read more through going back to this webinar, and also by sharing any material that we could share with them. And thank you for sharing also your contacts. That also, I'm sure, will be very helpful for those who would like to further discuss with you any specific points. Before going to the Q&A section, I would like to share quickly with our participant what are the available tools right now in Lebanon that they can use, because some of them may not know about what's already available. So we will share with you this document that shows you very quickly with links into what is available. First of all, we've developed with WHO a series of self-care videos with every video specific title. Why do we take care of ourselves? What are the effects of the stressor? What is self-care? What is the impact on frontliner? What is burnout? What are other mental health conditions that might arise? What are the tools for the self-care? What are the strategies, positive or helpful strategies to cope with stressors? A lot of them have been already mentioned by all of you. Some grounding techniques, some slow breathing techniques, reprioritization exercises, problem-solving techniques as well. And also, we share here with you a link to the 4 Ws, which is who's doing where, when, what and until when, which is the platform that Dr. Karam mentioned, where you can click, check in which area you would like to see a psychiatrist, and then you have a list of the affordable ministry-led with our partners services that are either for free or other very affordable. I mean, for you or for your patients. We have also the 1564, which is the National Emotional Support and Suicide Prevention Hotline that the program runs with Embrace, who's a local NGOs, where you have 24/7 someone who will pick up the call, who is well trained and supervised by psychologists to de-escalate, provide initial support, and then refer you to those services. This is the link to the 4Ws. We have here also the link to the step-by-step application, which is a guided self-help intervention developed with WHO and many partners. We did the 2 randomized controlled trial on 1,250 patients and have proven to be effective for depression and anxiety. All of those services are, of course, for free. And last but not least, to link it up also to Dr. Soraya, we started with WHO, an initiative for mental health in the workplace, for which also we teamed up with IDRAC, rolling out some trainings. You can find more about those information and a lot of tools on this link as well. So we will share this document with you. Please feel free to share it around as well, as widely as possible. Now we will take some questions. So we have in the Q&A round 5 questions. I'll go through them and then see who from the colleagues would like to respond. And meanwhile, while we respond to the question, there will be some poll questions put for you so we can get your input into how we can improve those webinars, because this is the first webinar of a series. So if you can please take the time to respond to those polls while our speakers respond to some of your questions. So we have a question about if there's something specific related to the fact that you are a radiologist and how to deal with patients stressed as a radiologist. I think that may be more for tips, probably to calming down patients if they're stressed when going MRI and other things, probably. I don't know if any of the colleagues would like to answer this, but I'll go through all the questions just so you can get a sense, or you can read them as well. As panelists, you have access to that, to the Q&A. We have another question about what can healthcare institution do to support doctors' mental health, and I think we have initial responses from Dr. Torbey's intervention, and there's any additional things that you would like, Dr. Torbey will get back to you. And there's a question that's more personal. If you can go, and I think that would be good for all of you to answer somehow, if you could go back, what's one change you'd make early in your career to better manage stress and prevent burnout? So maybe we'll start with that. Maybe have a quick answer from you on that. Then please feel free to quickly answer any of the other questions that you feel relevant to you. Who would like to go first?
I can.
Please go ahead, Dr. Karam.
Okay. The one thing I would have changed is to learn better time management and how to structure my day in a better way. The one good thing about COVID is that it forced me to be home, like many of us. And by being home, I learned that I can do so many things online. I can do so many meetings without being present, physically present. And that gave me a great opportunity to be with my kids and, to see them grow. And even though that COVID now ended, I still practice the same. So I am here, I'm talking from my home office, where I decided that every day I come back home at 5 and I continue working from home. So I work until 10 p.m. But just the mere fact of being home and hearing my kids outside the door, kissing them goodnight before they sleep and so on, that has been a big plus and a big joy for me. So learn how to manage your time early on and to prioritize, because that's how you will put yourself first and prevent burnout.
Thank you, Dr. Karam. Who would like to go next? Dr. Turbe or Dr. Bizri?
I can go.
Please.
I think it's something I still struggle with. I don't know how to say no. I think us Lebanese, once you compare yourself, we're pretty workaholics, and I just cannot say no. Whenever an opportunity comes that's pretty great, I will always say yes. So that's something I'm still working on. But another thing, I guess I wasn't as involved with some behavioral measures that can help, like meditation and things like that. And I took a course here that was very helpful, where I learned a lot of mindfulness and meditation. And I thought that was very helpful. And if I could go back and maybe use that more efficiently, like throughout my, like more regularly, I think that could also be very helpful.
Thank you, Dr. Surya. And to add on that, I think people in the health field, but also in the mental health field, we tend to be more on the agreeable side. So saying no is very difficult for us in general. And it's a steep curve to learn to do that. And in terms of time management, there's a very interesting book, by the way, by Oliver Berkman. It's called 4,000 Weeks, Time Management for Mortals. I would highly recommend reading it, because actually it goes exactly into that point where time management, okay, we can increase our efficiency, but at the core, time management is a process of learning to say no, not to things that are not important, but to things that are important, to focus on more important things, because the 4,000 weeks is our average life, actually, in general. So that's a nice book and a nice read if you'd like to learn more also about that topic, dear participants. Dr. Maya.
Oh, it's hard to respond after all your responses. But I think one thing, I think we're taught, I don't know if it's a medical thing, a school thing, or it's a Lebanese thing, that you have to be good at every aspect, or you have to like every aspect of medicine. And I just don't think, meaning that you have to be a good researcher, and then you have to be a good clinician, and that you have to be good at, or just like all of these things. And I figured with time that, you can be fantastic at one thing and just be okay with saying, no, I'm not interested in that part of medicine, and be okay with it. And that doesn't make you less of a competent physician. I think it's something I struggled in during med school, at least in my medical training. I hope my medical school is not listening, but I just, I think I've learned it, like beyond residency, especially in the US, that, it's okay to like one aspect of it and do it really well. And the other thing, I think Dr. George is the expert here, but I think I never liked exercising, but I very recently started enjoying it, very recently, meaning like 5 years ago. And I'm surprised, because it used to be like PE used to be the class I used to run away from in high school, probably. And just now it's something that I look forward, and it becomes a daily practice, honestly. And I just, back to his point, I think we see ourselves as very different from everyone else in society, where as physicians, whereas we're just, it's just that they get to start their lives a bit earlier, I think. And I just think we start to take care of ourselves much later.
Thank you, Maya, also for your insight. And just as to rectify something, I ran for a while, George, back then, but then I stopped running. So just, to say that it's really difficult to keep up physical exercise as a habit. And once it becomes a habit, it becomes very easy to do. And the benefits way outweigh this hassle of starting it. But I'm in constant negotiation with my mind about it. Hopefully, I'll get back on track very soon. And in terms of taking it easy, I think it's even more difficult for women. I think the pressure on women is even more, because there's expectations on them being excellent professional, especially probably in Lebanon, probably in other countries, or women of Middle Eastern origins, where they have to be perfect wives, perfect mothers, perfect professionals, successful entrepreneurs. And I think that, I've seen it, and all of us, I think men who have beautiful, amazing women in our lives know that the pressure is way more on women. So just acknowledging that and saying, like, take it easy on yourself, dear colleagues. You're already great the way you are. Now, going back to some of the other questions that have been asked, does any of you colleagues would like to answer any specific question that from the question list that you've seen?
You know,
Can you repeat them? Honestly, I can't see them.
It's on the Q&A section. As a panelist, you can see them. If not, I could look back again into them and give you. So what changes can healthcare institution make better? I don't know, Dr. Torbey, if you have like, really, you have an elevator pitch and you have the CEO of a hospital and you have 3 points to tell him. What would you tell him? From all these amazing interventions that might happen, if you have to select 3 things.
I'll work on leadership. I think that's one thing that trickles all the way down to everything. If you have good leadership, you're going to have someone who works on the resources. You're going to have someone who takes care of like resident wellness. You're going to have someone who wants their staff to be happy. And it's directly related with burnout. So I would do that one first. Second, I think I would like to build something. I mean, we're talking like, I'd like to have something built in for people to be able to access some access to care, like whether it's something that's similar to RISE, like it's a psychological first aid where you can like, it's pretty easy to like train people, things like that, where they can call and kind of reach out to them, and you can have one person on call for a month or something like that. That would be something I potentially would feel would be helpful. And you told me 3 things, and focus on your trainees. You know, they're not workhorses. Like we've all been through it. We all hated it. It was awful. I was so burnt out in fellowship. I had a picture there where it shows like me and my co-chief, who looks miserable in the second picture, but I didn't show it to you guys. But it really is like, it's important. Like don't want them to like graduate feeling like we hate medicine. So I would say those 3 things.
Thank you, Dr. Torbey. And back to you, Dr. Bizri. There's a question about how to deal with the guilt of giving priority to our well-being. Since you spoke about, vicarious trauma and also moral injury, so I thought that this might be something that would be more close to your presentation today. Any advice on
dealing with the guilt of prioritizing our own well-being?
Yes.
Well, going back to first 2 things. Going back to the metaphor that Dr. Karam said, I love it, about the cell phone that is not charged, and not being able to care for others, whether that's back home or that's at work. But the other thing, I think part of dealing with it is based. That ACT therapy, where you just based on your core values and really thinking about, what am I doing this based off of? Am I doing this because I'm selfish? Am I doing this because I'm negligent? Or am I doing this because this is the best that I can do at this time? And if you really go back to the value that you're doing the ACT with, and think about, no, I'm doing it with the best resources I have at this time, including my own capacity, then you can really do things without feeling any guilt. That's for any choice in life. I feel like if you go back, does it align with your own value system? Is it what am I basing myself on? And if you think about it, it's never about being negligent or selfish or being an incompetent physician or incompetent parent. I think going back, doing that exercise frequently makes you feel much more at peace with your choices. Does that make sense?
I mean, it does for me. Dr. Karam, would you like to add anything from your end on this specific point?
No, I completely agree with Maya. I completely agree.
Yeah. I guess, it's just like also making space for guilt, that it's a natural human emotion that we shouldn't fight at any cost. It's learning to deal with that feeling, giving it space, as is with a lot of other difficult feelings. it's fine to feel the guilt. It shouldn't be necessarily dictating everything we do, especially as you said, Dr. Bizri, if the meaning and the value behind it is not just a mere selfish action, but to take care of ourselves and others. I think that would answer most of the questions that I see here in the chat. So with that, I think we will be ending our session today. So a huge thank you first for our speakers for taking the time, for sharing your experience and expertise, for ALMA, for IOM, for Dr. Ahmar, for of course the leadership of Dr. Abyad that promoted this initiative that we hope it will continue. And a huge thank you to Maryse, who's been really doing an amazing job pulling this webinar together, helping in the organization. So thank you so much, Maryse. The next webinars will take place on Wednesday, February 26th and March 26th as well. In case there will be any changes, they will be communicated to you based now on the poll also and your responses to the questions that you were asked about when and you would like to have those webinars. So thank you all again. Have a good evening and good afternoon for those who are not in Lebanon, but more on the other side of the globe. And thank you again. Very appreciative of your support and hope we will connect soon. Bye-bye.
Bye.
Bye.